We know that we've got a strong trend towards improvement in overall survival, but because the POUT wasn't powered for OS as a primary endpoint, it is underpowered for that. But there is a strong signal, which I firmly believe, and we can see that the disease-free survival, the long-term effect for the patient on something that's clinically meaningful, that matters to them, are they cancer-free or not, is in favour of chemotherapy. At 5 years, there's a 17% difference between surveillance and adjuvant chemotherapy. And because this is chemotherapy that we give every day in metastatic urothelial carcinoma, whether upper or lower tract, we know how to manage the side effects. There were no additional side effects from these commonly given drugs in this patient group. So it's a safe treatment, it's an effective treatment, and it's delaying the time to progression, and there is a strong signal towards overall survival. The things that were particularly interesting from the study was obviously the fact that it doesn't matter type of chemotherapy. That was, and also the fact that we met the endpoint early, you know, in terms of our disease-free survival, and that's really a tribute, as I say, to the uro-oncology community across the UK, who really got behind this low incidence tumour. And the first time we presented the data at ASCO GU in 2018, the first question that I was asked wasn't really a question, it was a statement, which was, congratulations on doing the undoable, because until POUT came about, this was thought to be impossible. Now, the interesting thing that's happened subsequently is that we can see from a number of other studies that have looked at adjuvant treatment, predominantly after cystectomy, but there was, you know, up to 20 or 30% of upper tract patients allowed within those studies, that checkpoint inhibitors don't work in this group, which is surprising, because you would expect that because they've got a higher rate of microsatellite instability and hypermethylation in upper tract tumors compared to lower tract, that you would see, you know, that potentially checkpoint inhibitors do make sense. But we know that adjuvant nivolumab, the subgroup analysis, is negative for UTUC. We know in the Ambassador study that adjuvant pembrolizumab is negative. So how many more times do we need to be raising this question? It's negative, it's a bust, it's a waste of time. Where I think is interesting is looking at the role of the FGFR inhibition, FGFR3, with agents such as odafitinib. And that's because we know that the rate of FGFR mutations, deletions, fusions is higher in upper tract disease than it is in lower urinary tract disease. It's probably in upper tract disease more commonly seen in the earlier stages, so the PTA, PT1 tumours. But we estimate it's about 30% of patients with upper tract disease that's T2 and above that would have mutations. So it's an obvious and interesting target. There was a study, one of the proof studies, looking at one of the other FGFR receptors inhibitors in this setting, but the agent was withdrawn. Where do we go from here? Well, we're currently looking to see about, you know, what is the next best steps. We did have a number of ideas over the years, but actually what happened was the data from the metastatic setting, the advanced and metastatic setting, was looking at combination of IO with chemotherapy versus chemotherapy versus IO monotherapy. And that was in the metastatic setting. And those studies came back and they were negative. And so there was no point in doing what felt like the right step 5 years ago, which was to combine a checkpoint inhibitor with chemotherapy, because those studies were negative in the metastatic setting. And as I've mentioned, the checkpoint inhibitors in upper tract disease do seem to be disappointing, you know, in the adjuvant setting, with the other trials, with Ambassador and with the nivolumab study both being negative. Originally, it was slightly more at 3 years. So it was 21%, and now it's just gone down to 17%. So it's narrowed slightly. And that would be what you would expect, sort of with time and with more follow-up, really. So still a very strong readout on that. And, you know, one of the most important things for me, we touched on how grateful we are to our sponsors for this, for Cancer Research UK, for this academic study, which didn't have sexy new drugs at the time in it. and also to the trials team at the Institute of Cancer Research, who were utterly brilliant throughout the whole trial. But let's not forget the 261 patients and their families who went into the trial. And we had two really the most important people for the whole of the trial in terms of the running, the setup, the information about how to do it, were Chris Harris and Andrew Winterbottom. Andrew Winterbottom was also the founder and chief executive of the advocacy-based charity Fight Bladder Cancer 10 years ago. And Chris Harris was there on day one on our first focus group when we were trying to set the study up before we went for funding. And they both became members of the trial management group for POUT until from the very beginning until their deaths. And obviously future patients owe them and all of our 261 patients a debt of gratitude.